I was going to ask you about, CT planning and maybe robotics. Now, I think there's a lot of, info out there about whether the patient should try and aim for, the surgeon should try and aim for, robotic augmented knee surgery, which basically means you're using, if I'm right in saying, you're using essentially scans and the robot to show you where to make the cuts and where to make the incisions, rather than using the human eye, so that you get a better fit. Is that how it works?
Yeah, I mean, this is, again, a very common misnomer that, people think, oh, robotic surgery, it's got to be better, it's got to be more accurate, robots can do things better. And, you can argue, yes, certainly in terms of accuracy of cuts, that may well be the case. I think the fundamental principle is that actually is, what are you trying to achieve in this patient in terms of the prosthesis, the alignment, preoperative and postoperative. A lot of knee replacements are designed, we all know in normal anatomical knees, the medial side of the knee, the medial femur is the driver, it's the sort of the round, the lateral condyle is smaller, and actually the knee doesn't sit sort of perpendicular to the floor, it sits at a slight axis, and the tibia is shaped like that. You have a domed lateral tibia and a convex medial tibia, and that's how the knee articulates. Typically, when we replace knees, we're actually going for perpendicular, and so in fact, we're looking at something called mechanical alignment, and that may be right for that certain prosthesis. Whereas another prosthesis manufacturer, they're looking different. So, for example, when I do the Symbiosis, custom knee replacement, we're actually not going for mechanical alignment. We're going for what we call anatomical alignment, or actually it's been even kind of more superseded than that, something called natural alignment, which sits somewhere between mechanical and anatomical. So it's, the difference from a hip replacement is that, look, are you trying to create the patient's own anatomy? If they're naturally invarus, do you put them back invarus? Are you trying to correct them? If they're invarus, you're putting them to neutral. And this is where, mechanical alignment may have its drawbacks on that respect, because, if a patient's naturally bowed and you're putting them back into, straight leg, it looks good and the x-rays look great, but actually that may not be that good for the patient. And again, that 20% dissatisfaction that I mentioned before, that may be one of the key factors.